It's my and our great pleasure to introduce our distinguished guest today, a man whose reputation for magic knows no bounds. Whether it's pulling coins from behind your ear or making middle ear bones disappear, reappear, or reconnect, Dr. Duane Mol has mastered the art of illusion. Of course, when he's not amazing audiences with sleight of hand, he spends hands of his free time as a brilliant ear surgeon. Today, he combines both passions in a truly very special way. Please join me in welcoming the master magician himself, who also happens to be quite skilled with a scalpel, for his lecture, Magic Ossiculoplasty. Thank you so much. Duane is a great surgeon from South Africa, a good friend that I met in France for many years, and I'm sure that he's going to enjoy very much his talk. Thank you so much, my friend. It's the word is yours.
Thank you so much, Prof. Saji. It's a privilege to be here, and I've never quite had an introduction like that, so that was amazing. Welcome. It's lovely to be here from a sunny South Africa. We're actually also in our winter, being in the Southern Hemisphere like you guys, so we've had a bit of a warmer day. We don't have rain at the moment. We're waiting for rain. But I want to talk to you a little bit about ossiculoplasty using cement with what I've called the magic bridge. Now, please stop me if I'm going too fast. I think, Fabio, you'll just cut in if somebody wants to ask a question or anything, because I haven't got you guys on the screen. I'm just watching my screen as I talk. So like all good presentations, they show you the university where they're at. I'm working from a private practice in South Africa. I am also attached to the university. I work at the Nelson Mandela Children's Hospital. But at the moment, I'm presenting from that little window right over there. The circled one over there, that's where I'm speaking to you right now in Johannesburg. Normally we show you beautiful pictures of a lovely city. Johannesburg is not that. Johannesburg is a financial capital of South Africa, so it's not a pretty city at all. Why are we talking about ossiculoplasty? We know there's good standard techniques out there. The torps, the porps, the interpositions, stapes, this is well known. If we look at a big range of different ossicular prostheses, I mean, there's so many on the market. And my problem is that we live in a country, and I suspect it's similar in your country, where finances are a huge problem. And so when you open an ear and you suddenly need this sort of prosthesis and you don't have it in the cupboard, this is very limiting. And so many years ago, I thought I'd look for another solution, and that's where I came across cement. And obviously, you've got different situations in the middle ear, and that is why you need different prostheses. Well, until I found this Ketochem cement. Let me tell you a little bit about it. I don't own anything in the company. I'm a disclaimer that I don't make any money from any of this. It's made in Germany, but it's been used in the dental market for about 30 years already. So it's not a new product. It's a glass ionomer cement, and it's used by mixing the two ingredients together. It doesn't require a light, as some of them do, to dry it. It takes about 30 seconds to mix, is workable for about 3 minutes, is hard at 7 minutes. And we would probably use in a surgery 2 or 3 mixes per surgery. But I'll talk a little bit right at the end, if there's time, a bit more about the cement. That's just to tell you what's inside it. I know you're looking and you're saying, Duane, how do you present that to the surgical field in a sterile environment? And the situation there is well, we have a surgically clean environment that we would have to use it in. And I'll show you again a little video at the end of how we do it. We've never had a problem with infections, but I suppose the guys in Europe might say that's not technically 100% sterile, but I will show you. So we did try to use these capsules, once-off use capsules, but they haven't been helpful. They come out too thick. You can't really change the mixture consistency. So for me, getting a good cement is an important start to this, and this is the one we happen to use. Let's look at how they build bridges. Now, I mean, nobody builds a bridge with the cement truck just in the end popping out the cement. I mean, this is just going to fall over. And so in 2007, 2006, around there, my cousin is in the building industry, and I was telling him about this new cement I was using, and he said, oh, do you use the metal rods that we put in cement to stabilize them? I said, what do you mean? You know, these metal sort of, to keep the cement a little bit stronger, it strengthens the cement. It can also help it take the form of the metal rod inside of it. And suddenly something struck me, and I thought, well, maybe we should use cement in the ear with a core. And so this is where the concept came to me a couple of years ago. So we've now used, what core do we use for this talk? I'm going to call it the magic bridge, but it's really just 4-0 nylon. We've tried 1-0 nylon, we've tried 6-0 nylon. We found 4-0 to be the most user-friendly and giving us the best results. So to take the trouble away from you, 4-0 is probably the best as long as it's non-absorbable and it's nylon. Let me just give you a bit of an idea of what we would be doing. So here we have a situation in the middle ear where we've got an incus erosion. You can see that quite nicely over here. I don't know if you can see my pointer, but there you've got a nice incus erosion in the stapes head. And the options are possibly an incus interposition, possibly using some sort of prosthesis. But what we use now is we place the magic bridge. Now, I would first put a dot of cement on the incus, eroded long process. I'd put a dot of cement on the head of the stapes, and then I'd place the magic bridge across like that. You can see that. And then I'd build it up with cement, forming that sort of picture. So this is the situation. Let's look at the live feed. Let me know if you can't see the video. Is it playing?
Yes.
Okay. So here we've got a situation where there was a patient. She'd had a previous, I think it was a cholesteatoma many years ago, but you can see that stapes is incredibly mobile, almost a little bit too mobile. And I always had a problem with putting on a ossicular, incus interposition and pushing it down onto a stapes that's that mobile. So here I have a dot of the cement that I've mixed, and now I'm just putting a little bit on the stapes head. I'm then also placing a little bit onto the incus eroded long process. This is just a standard E needle or curved needle is what we would sometimes call it. I then quite quickly place my nylon. I'll explain to you now how I get my size of my nylon. I allow that to dry because there's no point in putting wet cement on a product that's moving around in the ear. So there's a little bit of drying. So there was a bit of a time lapse between what you saw now. I made a remix. Here's another remix. So now I'm placing a little bit more cement just to secure that nylon onto the incus. And now I wait for it to dry. And then I come with my bigger piece of cement and I just gently use the properties, which is really nice of the cement, to envelop that nylon core, and within 7 minutes I have a hard, very ossicle-like structure, and that would be sort of our end product. Let's quickly look. That was a nice post-op audio, but that's not what we're talking about today. We're talking about why, Duane, why did you want to stick it together? Why don't you just put something in its place? I'm going to talk about a theory. I don't really have a name for it, but some of the guys talk about this theory of the ossicle or the oval window footplate moves in and out, and both phases are helpful for the transduction of sound. If we go and put a strut or something on top between the, for example, malleus and stapes, you don't really get that pull effect as much, and so you really only have a one-phase hearing help, if you can call it that, for the hearing. Now, this is just a theory. I'm not sure if it carries a lot of water, but it's something that made me think quite a lot about rather making a secure connection in my ossiculoplasties. Now, we've heard about cement, maybe you've even used cement, and everybody's got that history of, well, I've opened an ear before where there was cement, and now there's just a piece of cement lying on the promontory. There's a little bit of dissolved, broken off cement at the side, and we must say we saw that as well. So that is why we use the core, which tends to hold everything together. And since we've been using that, we've never, ever seen a blob of cement in the middle. Yeah, no, it doesn't dissolve. No, we've never had problems with sensorineural hearing loss. We do remember there was that company that had to withdraw their, I think it was called Seronosem, there in 2016, after they had found that they were using the cement to reconstruct, reconstruct posterior walls, reconstruct the whole mastoid cavity, basically, obliterating the mastoid cavity. But the problem is that high concentration of aluminium that's given off by these cements could cause toxicity. And because it was in direct connection with the dura, they did pick up some problems. And so that was then actually withdrawn from the market and gave everybody a little bit of a scare into using glass ionomer cement. However, with the amount we use for an ossicular chain replacement, we have never seen a problem like that. I'm going to show you how wonderfully it integrates with the mucosa of the ossicles, the cement, and it sort of gets a whole blood supply of its own. And is this nylon core technique robust enough? I'll show you the stats a little bit later, but we've been doing this officially since 2009, unofficially since 2007. And I've got cases that I've done in 2009. I phoned the one lady the other day. She's still hearing excellently. That was just an incus stapes reconstruction like you saw earlier on. And there's no degeneration of the cement in any way. Certainly that's not affecting the hearing. I want to show you just an example of this. The original surgery was also for a cholesteatoma. You can see there's an erosion. I apologize for the quality of the video. There is an erosion of you've almost got a little bit of the incus long process still attached to the head of the stapes there. You've got cauda, and you've then got the incus body on the other side. So we're just going to do pretty much what we've shown. I'm going to leave the videos because it's nice to see, we can fast forward, but it's nice for you guys to see exactly. It's a very gentle process. We touch it. What I want you to just maybe see here is the consistency of the cement. We'll again discuss how to mix it at the end, but it's a softish. It's not hard. It's a little bit flowable, but not too flowable. And it's almost like wet toothpaste, if you could put it like that. That's sort of the consistency that you're looking for when you create that. Now everybody's going, Duane, we see the cement touching the cauda. Surely this patient had a taste disturbance. Well, believe it or not, we've never had any problems with the cauda and this. You can see it's easily separated. The cauda has not, we know sometimes you do a middle ear surgery and the patient will complain about a taste disturbance, but as a rule, it's no more than what I usually get, which is very few. So here we are reconstructing. Why am I showing you this in detail? Because I'm just showing you exactly what we did here. We had the incus long process sort of still attached to the stapes head. Okay, so now we've reconstructed that, and that's pretty much the end of the video. And so that was a nice post-op result then. This is 4 years later. She complained about in 2020, she complained that she had the fullness in the ear, and on scan we saw a little bit of soft tissue that we worried might be the cholesteatoma regrowth, and so we did a relook. I must say I was a little bit biased because I wanted to see what that cement would do. This is the exact same patient. Have a look at the credible way that this ossicle has now been integrated, the cement. It's got a blood supply. You can see the vessels on top of it. And, of course, the cord is still unharmed. But that is the exact same case. It's almost unbelievable. This is another case in 2013. And I just wanted to show you this was how we're doing a revision stapes, typical slight erosion at the tip of the incus. Here, we didn't have such I do this a little bit differently nowadays, but I'll show you that later. Here, I just moved the piston back over the area of the incus where it was stronger, and then I just used a cement to sort of seal up the tip so that it wouldn't fall off. I'm going to just fast forward for sake of time. So we would basically have that, and then we'd use a little bit of cement just to seal the tip. And you can see the cement touches a little bit of soft tissues. There's no problem. You can just suck that away afterwards. But here I am doing that. We're getting that sort of effect. Sorry, I'm just fast forwarding. I apologize. This is old videos. So that was our end result. Okay, a nice looking result. The good news is she had a nice hearing improvement. But now, 10 years later, she complained of a sudden deafness. We went back. We were worried about a perilymph fistula, and that's the reason we opened again. No, the sudden deafness was not because of the ketogam, because this has been there for 10 years. And so I'm just going to play these videos. The one is the endoscopic view. The other is the microscope view. And you can see, again, this is 10 years later, looking at that same cement. And, it's hardly eroded. It's hardly got smaller. Here's just a view of what she looked like before I opened the eardrum. You can actually see it's friendly to the drum. You can actually see it touches the drum, and there's no interaction, there's no reaction. And there it is again. So what do we do nowadays, Duane, if you say you do stapes revision differently? I had a terrible experience many years ago where a patient came for a revision stapedotomy, and I removed the piston out of the fenestra just because, it was bent and it wasn't looking nice, and I removed it, replaced it with a lovely piston that had what really looked like a great operation. Well, this lady had the worst dizziness I've seen in many years after surgery. She carried on for 2 weeks where she could not get out of bed. Despite all our efforts, we then eventually tried, we obviously the cortisone and all the different things. We tried numerous things, but I eventually had to go and remove the piston, and that was the only way, seal up that oval window, and that was the only way her dizziness disappeared. So we never know quite if there's an attachment of one of the inner ear structures, the vestibular inner ear structures, the saccule, the utricle, to the base of that piston. And, I suspect in that case it was that caused her dizziness. So for me, when I go back for a revision stapes, and I'm just going to play this along while I talk, I'm very reluctant to pull out the piston out of the oval window for this reason. Obviously, there's a much higher risk of sensorineural deafness as well. And so what you're seeing here is a technique that we did a couple of years ago, where we put the little nylon through the piston loop, and then we're going to build it up onto the incus again. So you would have said to me, Duane, why don't you just bend it like you did on the previous one over the remaining incus? In this case, the angle was too acute and it was under too much tension to do that. And so we just tucked that little nylon underneath. We placed, like I said, the ketochem over here, attached it. I normally leave about a third at least of the length of the nylon over the incus so that I can ensure that it makes a stable connection to the incus long process. And then we slowly just built it up with the, I'm just going to move for sake of time again, on both sides of the piston, and then eventually envelop the whole piston to leave us with a picture looking something like that. Nice movement. Remember, this dries with quite hard already within 5 minutes, super hard within 7 minutes, and we can close the operation. The nice thing here is these patients wake up, there's no dizziness, there's no risk of sensorineural, very, very little risk of sensorineural hearing loss, and they really do well. She also had a very nice response. So, what have we learnt about ketochem? We started, as I said, in 2009 officially with it. It's robust, many years. It's still working well. It's able to be enveloped by a good blood supply with little to no erosion, which is quite interesting. You could get a blood supply around a cement. Who would have thought that would happen? But we've seen it, and it happens all the time. The nylon core system definitely is stronger, and you'll see now when I show you another revision, I had to go back because the nylon core system I haven't been doing since 2009. That only started in about 2013 where we started using the nylon core system. It can be lasered, and in some cases we've used it to just laser a groove in the incus, reconstructed incus, when we do a stapes onto the cement, and then you just want it to sit nicely. So it can be lasered. It doesn't cause any fires or anything like that. I use a contact diode laser. New ketochem can be applied to old ketochem. I've only done that in 1 or 2 cases, and it hasn't given us any problems. Can you apply it to the foot plate safely? Now, firstly, I don't think it's a good idea to apply ketochem, this glass ionomer cement, to the foot plate, because there's a very small margin of error there where it can easily roll over to the side. And because this stuff really hardens quite quickly and hardens tough, it will fix that foot plate very easily. But sometimes you get that foot plate where there's just a little nubbin, if I can call it that, like a little tree stump of anterior or posterior crus that's still available for you to work with. And it's those anterior posterior crus nubbins that I often will just use a bit of ketochem on to be able to fixate the PORP or whatever to the foot plate. So that helps us. In the presence of open perilymph, there is no evidence of sensorineural hearing loss. This wasn't done on purpose. This is just when I do my stapedotomies. Sometimes you've got a very thin incus and my piston hasn't really crimped very nicely, and then I'll just add a little bit of ketochem onto the piston, at the connection between the piston and the incus, just to give it a bit more of a tight seal, and we've had no issues with sensorineural hearing loss. We have measured it. We have done studies. The weight is very similar to the ossicle, obviously the same size. That has been done. The nice thing is it doesn't adhere to silicon, which if you needed to protect a structure, maybe there was a exposed facial nerve and you're a little bit nervous, you can just slide a little sheet of silicon between where you're going to be working with the cement and the nerve, and you can protect it. We've had no adverse effects when it comes into contact with the quarter. And the nice thing is immediate mistakes can be rectified. If your reconstruction isn't so great, you can break it down, start again, and it's quite easy to do. I want to show you a revision stapes case. Now, this is the revision that we did a number of years ago. I forget, we'll see now the dates. But there you can see this was a patient that actually saw me. It wasn't my primary surgery. I just did the revision. You can just see in this lots of scar tissue, you can see the stapes loop piston, and obviously the incus that I've just cleaned up after a little bit of cleaning with the laser. Now we're sitting with the problem that that is quite far over. We've got quite a bit of an erosion of that incus, and so we try and bend the piston over for sake of time. I then realized that's not going to work, and so I put a nylon magic bridge, if you want to call it that, just like we've seen now through there, and we got a nice post-op. But what about a second revision? So that's how the standard revisions work. The second revision, this is the patient I was actually talking about. I apologize. The first revision was done in 2008, and then this was the second revision. In the first revision, we're just going to watch here. You can actually see the piston came through. Now, this is the one I got confused with the two videos. This is the one that was referred to me, a patient that had a piston pointing through the drum, very awkward situation. And when you look behind, you can see that we've just got that eroded incus that you can literally just remove the tip of that incus. It's just come straight off. And we were able to refit the stapes. And this time we were fortunate. We did a new fenestra, and she didn't have much dizziness. But here I just glued it back into position. This was before I used the strut. And that's what you see there. Well, a couple of years later, in fact, not many years later, she was flying to the Greek Isles on a holiday. And as the plane landed, she said she suddenly couldn't hear. And when she got back from holiday, we took her back. This is about 4 years between these two videos. And here you can see exactly, we've got the incus, and now we've got this mass of ketochem sitting on the piston, all right, on the loop of the piston, and it's off. So I just use the crocodile, and I crack the ketochem cement like that quite easily, and I remove it. Obviously, you're trying to be very gentle because you don't want to irritate the piston in the fenestra, and you can see it's not going to fit. And it's here where we then used our little bridge and reconstructed that, and was able to then, sorry, just for time, I'm going to finish there, get a nice result. And so that was her first, when she came to see me, we repaired it, we got a nice result, but the cement came off. And that's then the second one, which we then took back, and using the nylon bridge, that's where we've got our result here. Not only do we need it for, is the ketochem a nice idea to have in the cupboard as an emergency for any procedure while you're doing middle ear surgery, but this was a really rare case. And I'm sure you're probably never going to see something like this in your life, but this is a patient who had a accident as a young child, motor vehicle accident, and always had a slight conductive hearing loss. It wasn't a large conductive hearing loss. And here you can just see that the incus is just not touching the stapes. This is the endoscopic view. So you can just see it's sort of like a little bit of an aberrant. It almost looks like the head of the stapes came off with the incus at that fracture. So what did we do? Well, this was very easy to repair with, you can see the stapes moved nicely with a nice round window reflex. And all you needed to do was just, to go and do a whole incus into position seems like an overkill here. So all we did was just put a little bit of cement. But even in these cases, these small cases, I always leave a little bit of a nylon strand just to secure the cement, to make sure that it's a little bit stronger, and then obviously built it up a little bit after that. And we had a nice result. So that's the final product attached to there. And he didn't have a massive airbone gap to start with, but it fortunately closed. So that's our result post-op. This is an interesting case. This is a patient where I did a revision. And remember, I talked to you about the stapes footplate having a little nubbin or a little tree stump of the posterior cruce. And that's what we're seeing here. There was a little bit of the posterior cruce available. I'd originally attached it to the posterior cruce, but I hadn't really attached it very strongly. And I'd attached the other end to the malleus that I'd relocated. So the malleus has been relocated, and you can see it's still attached to the drum. And here, when we're touching at the bottom, you can see the mobile footplate, the little nubbin, but this has come loose. And I was able to go back quite easily. This was the ketochem rebuild. Sorry, the one is the endoscope and the other is the microscope, where we can see the clear difference in the visuals. I apologize, this was a while ago. And you can see that we needed to actually reconstruct or reconnect that base of this, well, now malleus stapedioplasty, reconnect it from the nubbin of the stapes footplate back to this prosthesis that we'd originally reconstructed using a nylon strut. I did redo the nylon strut just to replace it, just to reinforce it with a little bit of strength. Sorry, first time, I'm just going to fast forward again. So you can see, you can stand it straight up. If it's dries, it'll stand in that position. It's really, really strong. So that's the little nylon looking at us. And I was just positioning a little bit better. I wasn't happy with that position. You can see that I'm moving it into position. Eventually, that position is better for me. I've now probably mixed the ketochem 2 or 3 times already in this case. I'm just slowly attaching. So you don't want to dislocate that nylon bridge now. So one just slowly puts it in there, lets it dry. The minute it dries, there's a little bit of stability that you can then work with. And then you can slowly build it up to, again, retach it to this malleus reconstruction top, or whatever you want to call it. And now I'm moving the malleus and we're getting a nice round window of reflex at the bottom there. I don't know if you saw that. There was a nice reflex there. And that's the endoscopic view of the reconstruction. Again, quite a nice hearing result post-op. So this was a case where we tried an incus in position and it failed. And I'm just going to quickly take you through that as well. I know we're on for time, so I don't want to go too long. I'm going to fast forward a little bit here. So I try to do an incus into position. I actually remove the incus. I'm here relocating the malleus. Once the malleus has been relocated, I laser. You don't always need to laser the head of the stapes, but sometimes if there's a lot of soft tissue, I prefer to laser it because I'd rather have the ketochem cement or the glass ionomer cement bond to the bony structure than obviously the soft tissue. And so if there's a lot of debris on the stapes head, I will use the laser, but as a rule, not always. And there you can see a similar reconstruction. Again, we're using it to the base of the malleus. The important thing here is we have relocated the malleus to be over the head of the stapes. Otherwise, it would have been quite far away, and our forces, our vector forces, will be a little bit off in terms of getting a nice hearing result. And then you just allow that to dry, and it's quite a nice result. Apologize for that video. Right, so what happens if you do mess? And so in real time, we're going to watch this video. This was another case where I'm putting, again, some ketochem on the nubbin of the stapes head. Not the stapes head, sorry, the nubbin of the stapes posterior cruce. And you can see I've put it down there. It's on the nubbin. And I suddenly see it leaking. This was maybe a little bit too thin, the mixture that I made. And so now I'm worried because that's obviously, if you leave that there, that's going to fix the footplate straight away. Now I'm leaving the video in real time just to show you that I've got lots of time still. I swap over. I don't stress too much. I ask the nerve, well, you can't see me stressing, so I'm just going to say I wasn't stressing too much. And we get the black suction tip or a purple suction tip, and we reconnect that, quickly get the suction going. And look, we've still got time. And now we come in, and we're able to gently just suck that away. Sorry for the waste of time watching paint dry, literally. I'm able to just gently suck it and suck, boom, and we're ready to start again. And so you can easily fix it if you have made a mistake, and essentially that's similar to what you've seen now, a malleus to stapes nubbin reconstruction. So what happened here was we were using the magic band, or the magic bridge, and we were reconstructing an incus. So I needed to do a stapedotomy because there was a fixed foot plate as well as an eroded incus. And so here I'm reconstructing the incus to lie right over the foot plate, which was nice. That was nice and reconstructed. And now I was going to go and drill the fenestra. And so I drilled it. And as my drill's touching it, you can see I cracked the ketochem. So I'm going to drill the fenestra. I'll continue to drill the fenestra. You can see the ketochem is unfortunately cracked here. I've made my fenestra. Now I'm going to place my stapes piston. But just before I do that, I was able to just reconstruct again and just reinforce it and wait for it to dry. And that incus was then solid again. And I was then able to place my stapes around this incus into the fenestra. That was a nice result. That was a big airbone gap. So I just wanted to show you in sort of animated terms what we mean by a full rebuild of the incus with a stapedotomy, because that's a very nice benefit to have in these situations. So this is a case where this is all you've got left. You've got a partial malleus, maybe touching the drum. You've got a really badly eroded incus, and you've got a fixed foot plate. So where to from here? Yes, there might be some options you're thinking about you could use now. What we use is we first reconstruct the malleus and the incus joint, so that's stable. We then added a curved, just because I needed the position to be a little bit different, just a little piece of nylon. We then, that's the magic bridge, obviously. We then built that nylon up with the Ketochem. Once that was dry and strong and that we had a nice movement, we were then able to do the fenestra in the stapes and then place. Now you can see Sergi's laughing, Prof. Sergi, because his drawings are much better than my drawings. There's me trying to draw. And he replaced it's supposed to look like a stapes piston going through the foot plate, just to show you. So, and then obviously reinforce the incus again with these Ketochem cement. So this is what the case looks like in real life. Sorry, this is a, so here you can see the malleus and the incus. They're both mobile, but they're not actually attached. So that's malleus that we're touching there, the little remnant of the malleus. That's the incus that we're touching there. And these guys are not talking to each other. Okay. So what we're going to do first step is to join those two together. So we do that over there. We then, with that cement, I used a bit of a curve because you can see the incus was very badly eroded and we had a very prominent facial. So I wanted to get other side of the facial. So I had quite a long incus process here that I rebuilt. Once that's been rebuilt and allowed to dry and it's quite solid, we're then able to do the fenestra with the drill. That's then done. We get a nice movement by moving the malleus. You can see that whole complex moves very nicely and it's very sturdy, guys. I mean, they use this obviously for the teeth to glue teeth in the Ketochem, in the dentistry. Here, unfortunately, again, the microscope, not too great a view, but I'm just showing you where I'm doing the fenestra. We're placing the stapes piston, and I use the smart piston. The smart piston, I just use my laser. And you can actually see as I laser it, it crimps in such a way that it actually fractures the Ketochem. You can see there's a weakness in the Ketochem over here, and it's just lying behind the corner, difficult to see, but it actually fractured it. So I was just able to go back, just reinforce that slightly with some more Ketochem, and the problem solved. So really nice to be able to do that and have that ability. And now you can see very nicely, if you move the malleus, the whole complex moves nicely, and there's a nice response post-op. That was that hearing response. This was just an interesting case. I'm going to fly through this because it hasn't using the nylon core, but it was just an opportunity to repair a malleus head fixation, which we initially suspected actually incorrectly because the patient's medical funder wouldn't let us do a CT scan. We did one afterwards and found that where the fixation was, but we didn't know. We were going in thinking this was an otosclerosis, and we actually had there was a fixed malleus. And so when I opened up, I used the laser to remove the malleus head, separate the malleus-incudus joint, and then reconstruct using a nylon bridge the malleus, the now mobile malleus neck to the incus using the cement. And then I could reattach this because he did have a mobile stapes. And the only reason I disconnected it here at the stapes incudus joint was just because I didn't want to, with doing all this other work, I didn't want to create that extra energy transfer to the oval window. And this is actually the operation. I'm going to just fly through it because I'm sure we've got some questions and we are almost at the end. So I'm just going to show you that there. So it was fixed. I'm moving the malleus there. It's not moving anything. It's fixed. And so we can see the incus is moving, but the malleus and the incus are not moving together. We then did a couple of lasers. It's quite difficult to see, and I apologize. Here I'm lasering between the malleus head and the incus. Once I got the malleus loose, you can see it's mobile now. The incus was then repositioned. I'd actually removed it slightly, and now they were loose. So now the malleus and the incus are not talking to each other. So we obviously have to reconstruct the malleus to the incus. That's done with our little bridge, as you can see there, and then placing a little bit of our cement again. That seals that up. And once that was nice and strong, we were able to reinforce the staple. You probably could have left this joint. I just felt more comfortable reattaching the incus to the stapes head. But if it's really nicely aligned, you can probably leave it, and we got a nice result. So initially, not a good result, 2 weeks post-op. And then 6 weeks, it moved up to there. So after seeing all these videos, what conclusions can we come to? So glass ionomer cement is a lovely tool to have in the cupboard, but we haven't really found it brilliant with absolutely everything. And I don't want to take away a standard stapes. That still is the best way to do a stapedotomy. I don't think you really need cement for that. But we have found benefit in 3 very good areas, and that's the simple closure of the incudostapedial joint dissociation, where we find that eroded, long process of the incus and the stapes head, that gap. It's perfect for that. And obviously with the nylon bridge, that makes it not too complicated to do. My second indication that I've really benefited from was the revision stapes that I've showed you, where there was an opportunity to revise the stapes without removing the piston from the oval window. And I think that just made it much safer. Interestingly enough, we actually, of 58 cases with doing it like this, we've seen overall 4.8 decibel better improvement. However, that might just be because I've done these more later on and I got a little bit better at it. What is interesting is the incus long process, the total erosion with a fixed footplate. And we've only got 34 cases. That's this last case that the second last case that I showed you, that where you had to rebuild the incus and you had a fixed footplate, usually due to a tympanosclerosis. We had better hearing results than with the malleus stapedotomy, and our average improvement was 13.9 better in 34 cases. So that, for me, in my hands, are my three main indications to use glass ionomer cement. This is just to show you that it's, even though in this case we had a fibrous band between the incus and the stapes head, I still always prefer to put in a nylon bridge. Just while we're on it, you say to me, Duane, how do you measure the nylon bridge? What I actually do is I take my 4.0 nylon, I take a little galley pot, and I take the nylon under the microscope, and I just take my scissors and I cut small little pieces, but with the galley pot right there, because the piece shoots off from the scissors and then it hits the galley pot, lands in the galley pot, and you've got a whole lot of little pieces in the galley pot. And then you can come out with just measuring different sizes to see what is the best length. So that's how I cut the nylon. So I cut it off. I have the stitch. Normally they just cut off this. We've got a few re-sterilized nylon sutures, about 5 centimeters in length, and I just cut off small little edges on them into a galley pot, of guessing what size I would need, and then obviously use the different sizes to just measure. And that's how I get to my sort of final use of size here. This was just to show you that it's always best to rather use the staples. Here you can use it in congenital conductive losses. This is just a complex case. It was actually incus, then a soft tissue, then bone, then soft tissue again, and then the stapes, which was a monopod stapes in a congenital case. So in the end, we actually used... we actually went from the malleus because the incus just didn't give us enough working space. And so here we are, just forming a initial magic bridge between stapes and malleus, reconstructing that. And closing up afterwards there. Right. So our results. So the number of cases that we've used the Ketochem, not necessarily with the nylon bridge, but all the cases, is 587. We've got, I can't give you the number with how many we've used the nylon bridge, but anything that needs to be bridged on a larger distance is always used now with the nylon bridge. For example, my last 50 torps, the ossicle repairs to the last 50 Ketochem, we had that 13.68 decibel improvement. But it was biased again, because possibly as you get better and you get older, you get a little bit more skilled, you probably will get better hearing results. I don't know if you're familiar with the Austin cartouche system, but the best outcomes with glass ionomer cement is with the Austin cartouche system B and D in my hands. The B is the presence of a malleus, but an absent stapes, but I must say a mobile footplate. So sometimes we're able to use that little nubbin on the footplate, you know, that crura, that posterior, a little bit of that posterior or anterior crura to reattach the malleus to. The other group where you've got no malleus and no, or put it this way, stapes and no stapes, was also an opportunity where we had, we were able to rebuild with the glass ionomer cement something out of nothing, if I can put it that way. So that's what we've seen in our hands. What have we concluded? It's a backup tool in the theater cupboard. No, I do not use it for every case. I still do have some torps in the cupboard for specific indications. Very seldom, though, am I using them nowadays, because the cost is just getting a little bit too high for my patients to manage. We've seen the blood vessels easily cover the surface of the ossicle. Sorry, I want to go back to point number 2. I don't want us to suddenly now use this so-called magic glue in the ear just because we've got poor technique. For example, if you've placed a torp or a porp and it's a little bit unstable, now you've got to go and glue it into place. Yes, I have used it and it works very well, but we must be careful that we don't compromise poor clinical technique. I prefer a stable fixation. That's why I like to use the cement in most cases. And revision surgery obviously is possible. Always better to use the nylon core, and mistakes are easier to rectify when you've got cement in your hand. Thank you for your attention. I've gone all to 45 minutes. I apologize. let's end there. Maybe one video quickly, just to show you how we mix it. Sorry, this is worth looking at. Yeah, you can hear me counting down. Right, this is how we do ketogenic. Just show them the screen. We've got a double fact. Okay, open that up for us there. So that is the lid and a spoon that's sterilized. And this mixer is all stored in there. Move that out there like that. And then over here, you can have a look. Open this. Back tight and on. So I've got the spoon, the mixer, and the little lid. She gives me the bottle of activating fluid. You can open just take the lid off, yes. So this is a little bit dubious because she's unsterile and I'm sterile. That, however, is sterile, that packed. I don't touch the glass. My nurse then will clean that as best she can. Then we place it in a galley pot, which is marked for this, and therefore that area we will call it sterilely, but it's an unsterile area essentially. This bottle only gets opened when we do surgery, and it's immediately capped again, so the inside has stayed stable at all times and sterile as such. I use 1 spoon of powder and 2 drops. Again, I'm very careful not to touch the glass if I can help it. We use 2 drops. Sometimes the first drop has got a bit of air in it, and it's not a full drop. So I tend to sometimes turf the first drop to the side, and then the next 2 I place on the cement, the powder. It's like cooking when you've got eggs and flour. You've got to roll the eggs into the flour, and it takes about 30 seconds to mix. And then I use an applicator, which is basically a curved needle to just pick up a little piece there. And that's how we do that. Right. I hope that was easy to understand. I hope I didn't speak too fast.
No, Duane, I'm sorry for the cliche, but your presentation was just magic. It was really good, pretty clear, and I think most of the people here could understand pretty well. So I will open up for questions, and I'm sure that some of our associates here are going to ask you some questions. So it's open.
My name is Otávio. I'm from the rhinology area. Are you listening to me?
Yes, I can hear you.
So just to say congratulations, and when the lecture started, once in a while when we see lectures like yours with new ideas that in a way seems so obvious, they are so magic, and so congratulations, not just to have good results, to find ways to help people without a large amount of money and the same way. So thanks for your lecture and congratulations for your ideas.
Thank you very much for that. I really appreciate it.
I think that Neil Spellman just joined the conference, if I saw it well, right? Well, Duane, one of the points that I think that's we always discuss in Béziers is about stability. And I'm pretty sure that with this kind of reconstructions, you have a better stability than, for example, PORP on the top of the stapes, because sometimes we finish the surgery, we put some gel foam around, and we feel a little bit afraid that, that balance thing and the first sneeze of the patient is going to, fall apart. So in my mind and in my opinion, I mean, maybe this is your technique gives a more stable structure in the long-term basis. What do you think? Do you have any kind of comparison with that?
I have to be honest, I have actually in the early days when we were using, I nowadays don't use many PORPs, but in the early days when I did still use PORPs, I used a little bit of cement on top of the head of the stapes to glue the PORP into place. So if you are uncomfortable with making the bridge, you can use a little bit of that cement to make a stable, glue the PORP to the stapes head. The only problem, and while I'm a little bit reluctant about that, is if you cover, you get those little bell couplers that go onto the stapes head. If you've got glue on the inside of that bell coupler and you've put it on top, you are not going to get that off. If something's, it's very difficult to get it off without damaging the stapes. So my new rule is I have to see the cement. I don't like to hide it, because if it's hidden away and it sticks tight, you could dislocate ossicles. So maybe that's the only comment I can give on that.
And I think you have mentioned that, but you have some opportunities that it got really close to the stapes. It's not ototoxic at all, if I understood.
Absolutely not ototoxic. So look, glass ionomer cement, let me just give a minute of that, is it does give off aluminium. That's how it gives off aluminium, and that's the strength that it bonds. However, the amount is so minute when you're doing an ossicle repair that it isn't significant. We have, on one or two occasions where we've had a cholesteatoma, massive cholesteatoma, and we've had an open lateral semicircular canal that's been eroded, and we've got maybe a stapes that's been dislocated and there's a bit of fluid, and we were using ketochem, we've never seen a problem. But I have to say, I only can comment on when I've used it in stapedotomies and put some ketochem on the incus to stabilize it. We've certainly never had anything have a problem, but certainly not on the foot plate. You know, if it's not going to be absorbed through the foot plate, no, the aluminium won't be absorbed.
Well,
can you hear me?
Yes.
Thank you, Richard.
Yes, I can.
A great lecture. I have a doubt about post-op infections. Do you have anyone among those years, or not only infections, but also maybe reactions, allergic reactions to the cement? Did you have one or someone?
You know, I know it's hard to believe, but we've never seen a reaction. I don't know if you can remember that one slide that I showed with that cement touching on the drum. It's very favorable to the drum. It almost acts like Teflon on the drum, which doesn't, you know, we see with the aluminium, it tends to erode through the drum, but this doesn't seem to erode through the drum. There might be somebody that could be allergic to this, but we have never seen a reaction. We've never seen. Look, hey, sometimes I reconstruct and I didn't do a very good job, and the cholesteatoma has come back, and I've had to go back and redo it. So there's been one or two of those. So, you know, but I don't think it was the cement's fault. I think it was the operator's fault.
Oh, great. And is still there any case you don't use the nylon, or nylon in all cases?
So what I found is the nylon just strengthens anything that's got a distance. But if I'm, for example, I'd separated the incostapedial joint because I wanted to test, and I saw, it's a malleus head fixation, like we saw there. I sometimes use a little bit of cement to reconstruct the incostapedial joint. I won't use necessarily a nylon strut there. I think that one that you saw, that gentleman that had a car accident as a young child that you saw earlier, where I put a little bit of a strut, I think that might have been an overkill. But I've just found that the minute I put a strut there, the cement tends to sit longer. I've only revised my own cases, and we haven't got many. We've got about 7 that we've revised of ketochem cement where it's failed, the cement has failed, only ones that I've never used a strut in. So I'm glad to say I haven't yet had to revise one with a strut. That's not totally true, where the strut was the problem. Do you understand? I mean, I have had to revise one because it jumped out. But, okay.
I think we have a question from Neil Sperling.
Yes, Neil.
He's raising his hand there.
Can you hear me?
Yeah, pretty well.
Yes, we can.
Okay, I'm driving in my car, so I apologize. And I know I missed most of the lecture, but I'm sure it was beautiful because I saw Duane's talk when we were in France a few months ago. So hello from New York. I have a question, actually. I have a case coming up. I've had a few of these, maybe 3 total in my 30-plus year career, where a patient has a malleus fracture. Patient like stuck their finger in their ear to scratch it.
Neil?
Sorry, Neil, we're losing you.
Yeah, Neil, please repeat. We couldn't listen to you.
Neil, you cut out. As you said, we have 3 of these patients in your career, and then we couldn't hear what you said.
You got to the tunnel, Neil, probably.
Can you hear me?
Yes.
Yeah, now we can hear you.
Okay, so it's a malleus handle fracture. Have you seen that before, and have you used the cement to repair it? I'm thinking of whether to put nylon and cement for the malleus handle fracture.
Neil, if you give me a few minutes, I've got a video like that, but it might take a little bit long to find. But the answer to that question is I repaired it because that malleus handle fracture is definitely very clearly visible, and I did use a strut. But what's interesting is the hearing repair already wasn't a massive airbone gap, and afterwards it sort of only closed half the airbone gap. So I used it, and the patient's very happy because he had an autophony, he had a funny sensation with that malleus handle fracture, and that went away, but the hearing itself didn't get dramatically better. That was just in my hands. I've only seen one.
Is there any concern about the nylon just sitting underneath the tympanic membrane for exposure, or like kind of a nidus of infection or inflammation?
That's a good question. I have only got one, and I can't say it was. However, the nylon would have been under the malleus. You understand? Towards the middle, yeah. So the nylon wouldn't have been in contact with the drum, but the ketochem might have been a little bit in contact with the drum. But the nylon was sort of under the malleus. I reconstructed it underneath.
Wonderful. Thank you.
Thank you, Neil.
Thanks, Neil.
Duane, I had a case of a neurosurgeon that had an accident with scuba diving, and I have actually the picture in the CT scan with a small fracture on the tip of the malleus. And the symptoms was exactly what you said, not a big deal with the hearing, but autophony and things like that. But the gap was so small that, I did not indicate a revision case to reconstruct whatever, but maybe I will call this guy back and try to help him out. I don't know how he's doing now, but, maybe that's a great idea.
It's maybe give it a chance. I don't think you can make it worse, but I certainly, the patient was very happy that that funny sound had gone, but I was disappointed at the hearing result.
All right. Mauricio.
Thank you, Duane, for a wonderful lecture. My name is Mauricio.
Can you listen?
I'm battling to hear.
Okay, I have two questions, actually. We are using glasionomer cement since 8 years ago, and we have very good results also. But we have some questions sometimes. First one, about sterilization in surgical center. People ask about using a product that was not sterilized. And do you have this problem also in South Africa? And the second question is, did you have some case with fracture of the cement in long-term results, 10 years, 12 years, with broken cement in your case?
Excellent question. Let's start with the first question. That idea of the sterility, and that's why I showed that last video of how we do it. I hear that's not sterile, but the product, when it's bought, is said to be sterile in the bottle. So if I unscrew the lid, I'm in theater, I suppose dust could get in there. I'm using a sterile spoon to take out the powder, and immediately the lid is screwed back on. So nobody's allowed to touch that. If any contamination, we throw that bottle away and we get another one. Fortunately, our cement is relatively cheap. I can probably do 50 cases for the equivalent of 2,000 Rand. That is in dollars about $120. I can do 50 cases. That's how much the cement costs. It's not expensive. So if we feel that the lid was compromised, we will put it one side. The Medical and Dental Council, when I approached them, when they asked me to defend this, I explained to them that if we remember that the eustachian tube is connected to the middle ear and there is free flow from the nose and we don't always get infection, we have not seen any infection. I think the ear is used to a little bit of, if it has to compromise with a little bit of not totally sterile implement, if you can call it that. So we've not had a problem from our government. We've not also had a problem with our patients. We have not seen an infection because of the cement. Coming back to the crack, in the early days, without using the nylon cement, I definitely did see cracks in the cement. If it dries too fast, so sometimes I'm a little bit in a rush and I use the sucker to try and suck air past it to dry it. And in the early days, that cracks the cement a little bit fast. So I don't do that anymore. So that's just one thing. You can get those fine cracks. If you've actually operated 5 years later, the patient has now come back and there's a problem, I'm sure there must be, but they haven't approached me. So I have not seen a fracture with the nylon core. I have seen a fracture in the early days without the nylon core.
Thank you. Neil Sperling has another question. Neil?
Do I make a right to get to work, or do I make a left? No, I don't have any more questions. Sorry.
No. So in 1 week, I will be there with you, my friend. Wait for me.
Looking forward to it.
Duane, one last question here. If you have chronic otitis media cases with ossicular dislocation or disruption, do you stage the procedure or you go ahead and do at the same time with the tympanoplasty?
That is such a nice question. When in the early days, when we had to pay, our patients had to actually pay for the prosthesis. I felt a little bit nervous putting the prosthesis in at the first stage because they had to pay a lot of money for it and it sometimes wouldn't work. Well, there's not much to lose by trying the cement. If it works, you've saved a second operation. If it doesn't, you just come back and do a proper reconstruction at the second stage. So we actually do try at the first stage to reconstruct everything.
I think, Neil, you have another question?
News and the job.
I'm afraid not. Oh, I can lower my hand now. Sorry.
So yeah, please. That's pretty much Neil Sperling. So, any other question? I think, quite honestly, today is one of the most internationals of our meetings, and I thank you so much, Duane. It was such a nice talk, and I think I'm going to count on you if it's possible in the close future to have more of your wonderful cases. Thank you so much. Send my regards to your beautiful family, and I'll see you soon, my friend.
Thank you, my friend. Thank you for the invite. It was wonderful. God bless.
Hold a second. Oh yeah, we need a picture. We need a picture, and we also have here your certificate. We'll scan it and send you through the email, right?
Thank you very much. I forgot something.
Oh, all right. Go ahead. Go ahead.
I'm going to keep this in full view at all times. Saji, if you could just ask anybody in the audience to tell me red or black.
Yeah, vermelho, preto. Red.
Black.
Red.
Well,
Of red, diamonds or hearts?
Hearts.
Hearts. Okay. Any number in hearts. I know everybody wants to say queen of hearts, but make it difficult.
9.
9 of hearts. Watch here. I'm going to open the pack. It's not going to leave your sight. I don't want to. All the cards are facing you guys. Can you see that?
Yes.
All the cards. Oh, except for one card is facing me.
Uh-huh.
Can you see that?
Sure.
It is the.
Oh, boy.
Just a bit of magic. I couldn't go without some magic.
You are a better magician than a surgeon, my friend. I'm sorry. I'll see you.
Cheers, guys. Bye-bye.